Hello everyone, my name is Michael Hartung and I'm excited to present on upper gastrointestinal diseases on CT. I'd like to begin by acknowledging some of my awesome colleagues who collaborated with cases and material for this presentation. Let's start with the esophagus from the perspective of an abdominal imager. With experience, we have come to expect some typical variations of the esophagus when looking at the lower chest, from the nice and normal to the bulging hiatal hernia, and to reflux, with fluid distending the esophagus. And we have all encountered an esophagus that is simply too thick. When it is smooth and circumferential, you are usually dealing with esophagitis. Benign lesions, such as leiomyoma, can overlap with cancer, but are usually smoother, submucosal, and occur in a younger age group. And of course, you have to be careful about cancer. It can look like hiatal hernia, as in this first example. Oral contrast helps us to be more confident in this second example, which replaces air around the tumor that might otherwise look like rugal folds from a hiatal hernia. And finally, large masses at the GE junction can be easy enough to spot, especially with surrounding adenopathy. It is important to set a threshold for concerning findings where you recommend further evaluation with endoscopy or upper GI. In the emergency setting, things can get a little intense when the esophagus is thick and there is air outside of the lumen. This esophagus has been perforated as a result of repeating vomiting, which is also known as Boerhaave syndrome. And we all know what follows this diagnosis: a request for a fluoroscopic esophagram. These requests can be a bit painful, especially after hours. This important triaging tool is looking for the size of the leak, as this helps cardiothoracic surgery know if this patient can be managed conservatively or needs surgery. Unfortunately, these exams can feel like a mess with sick patients, limited ability to drink contrast, and difficulty with positioning. This patient presented urgently to the emergency department with a thickened hemorrhagic esophageal wall and pneumomediastinum. Clearly, there is a leak, and cardiothoracic surgery wanted us to do an esophagram to find it. But for the life of me, I could not find it in the fluoroscopy suite. I had the patient drink repeatedly, but could not locate the injury. This picture may be familiar to you: a larger patient, poor penetration of x-rays, and challenging with positioning, decreasing the sensitivity of the exam. So I improvised a bit and called our CT techs. I had the patient brought over for a limited CT of the chest after having him drink a bit more contrast on the table. After seeing the leak on CT, it is hardly a surprise that we could not see the leak in fluoroscopy, as it was projecting posteriorly along the spine and was a relatively thin and subtle channel. This useful workflow has now been formalized at our institution, and it is called the CT esophagram. It starts with the patient drinking 100 cc's of liquid on the table immediately prior to performing a chest CT. This study is better at detecting small leaks, gives you more information about the nature of the leak, and keeps our workflow more efficient. Let's take a look at another example. This patient had a tracheoesophageal fistula related to radiation therapy and underwent our CT esophagram protocol. These images clearly show the thin channel of communication between the esophagus and the left mainstem bronchus, with contrast filling the airway in the left lower lobe. This sagittal off-plane reformat shows contrast within the esophagus and the thin channel within the mainstem bronchus. We are able to make a confident diagnosis in this setting. This patient was treated with esophageal stenting. This next patient presented with chest pain after esophageal dilation due to chronic strictures in the setting of systemic sclerosis. Not only can we rule out a leak here, but we can also get a sense of the esophageal anatomy and overall length of the wall thickening and stricture. Here are 2 tips if you're considering adopting CT alternatives to fluoroscopic procedures like this. First, develop this in conjunction with your major orderers. In our case, this was the emergency department in cardiothoracic surgery, and you do this so that you can have universal buy-in. Second, while it might seem obvious, if you adopt something like this, give it the same name as the fluoroscopic order you are trying to replace in order to improve ordering recognition and compliance in the electronic medical record. But why should we stop at the esophagus? Let's explore how this technique can be applied below the diaphragm. The CT upper GI protocol can be utilized to look for gastroduodenal or proximal jejunal leaks, which could be caused by trauma, peptic ulcer disease, or cancer. You can also evaluate following gastric or duodenal repair, such as Graham patch, or for routine postoperative care, such as in bariatric surgery. It can also be useful to look for gastric or duodenal fistulas. Here is the protocol that we use. The patient drinks a mixture of water and contrast 30 minutes before the scan and also on the table right before scanning. Contrast can also be injected through a nasogastric tube or a feeding tube if needed. Here is a patient who had a history of gastric perforation and had the perforation repaired with concern of a postoperative leak. With this technique, we can have a high confidence for a negative study, and we can also rule out other pathologies such as hematoma or abscess with the remainder of the CT images. Here's another patient who underwent our protocol, where we were able to rule out a leak after injecting contrast through the gastrostomy tube. We also routinely obtain decubitus images, which help us to evaluate for subtle duodenal leaks at a slight delay from the first scan. Here is a patient who had a history of AAA repair and duodenal injury, who underwent our CT upper GI protocol. So you can see that there's good opacification of the stomach and the bowel with bright oral contrast, and no intravenous contrast was given in this case. As we scroll back and forth, perhaps you can see the site of leak at the duodenal jejunal junction here, where there's a thin channel of contrast leaking out into the left abdomen. And we can also get a sense of the degree of postoperative periaortic and retroperitoneal hematoma, giving us more information about the remainder of the patient's examination in addition to visualizing the leak. So that wraps up the esophagus and CT alternatives to fluoroscopic exams, and it is now time for us to continue our journey below the diaphragm and cover the important gastric pathologies that you should be aware of. As you know, the stomach can vary greatly in appearance depending upon when the patient last ate or drank. And this will change your ability to see the normal rugal folds of the stomach as it stretches out. And over time, with experience of reading many CTs, we all get comfortable with that range of normal. When the stomach is relatively scrunched up, you will see the rugal folds fairly well, like in this example. And when the stomach is full, like in this example with oral contrast, we barely see any of the rugal folds because they are effaced. Of course, the real diagnostic challenge comes in when the wall of the stomach becomes too thick. And generally speaking, we know too thick when we see it. So let's spend some time considering the causes of increased wall thickness. For our first case, the gastric antrum is too thick, and especially stands out compared to the rest of the stomach. But is it cancer? Well, notice how it's relatively low in attenuation, indicating that edema and inflammation are primarily the culprit for increased thickness. And indeed, this patient was referred to gastroenterology, where they found several superficial ulcers in the antrum on endoscopy. So what other scenarios do we see this pattern of low attenuation wall thickening in? Subacute and chronic pancreatitis are two common scenarios where you will see gastric wall thickening due to edema. Here is a patient with extensive low attenuation thickening of the stomach wall related to chronic gastritis with a history of chronic calcific pancreatitis. In this case of subacute pancreatitis, pseudocysts are dissecting into the wall of the stomach, compressing it and causing inflammation. There are also pseudocysts burrowing under the splenic capsule and compressing the splenic parenchyma. And in this case of infected necrotizing pancreatitis, the stomach is displaced and severely inflamed as a result of the infected walled-off necrosis, with both low attenuation edema and mucosal hyperenhancement in the stomach. This degree of inflammation as a result of walled-off necrosis was new and helped to raise the suspicion of underlying infection and was treated by gastroenterology with a cystogastrostomy placement. But low attenuation wall thickening doesn't always imply an acute inflammatory presentation. This is a younger male patient who presented with vague abdominal symptoms and CT findings of gastritis. After extensive workup, this turned out to be Menetrier's disease, which is a rare type of hypertrophic gastropathy resulting in hypoproteinemia. We've now covered some of the major inflammatory causes of increased wall thickness in the stomach, and now it's time to consider how we handle a potentially associated finding of air in the wrong place, starting with perforation. For gastric, pyloric, and proximal duodenal ulcers, you will see a characteristic pattern of free air. This occurs in the anterior abdomen in front of the liver, in and around the fissure, and also by the gallbladder fossa, and there's also going to be associated fluid. You may not always see the ulcer crater, but the pattern of air, fluid, and inflammation in the upper abdomen can help to guide your review and raise your suspicion. Oral contrast can be great for helping you to find the ulcer crater and should be considered for your initial exam or for problem-solving tougher cases. It is helpful even if the patient is able to drink only a small amount. In this case, oral contrast is leaking through this antral defect and coating the lower liver edge. This patient could not receive IV contrast, but had some free air and peritonitis. He did drink oral contrast before a CT, admittedly more than was needed, and we can see it layering here along the lateral and lower liver edge with some variable layering densities. The coronal image clearly shows the thin channel of contrast leaking from the perforated pyloric ulcer in this case, which helps to guide surgical repair and avoid a larger midline incision if the site of perforation remains unknown from the CT. An important ulcer variation to be aware of is a perforated marginal ulcer, which occurs in the setting of gastric bypass. These are often subtle and easy to overlook with postoperative changes in the upper abdomen that can otherwise be pretty easy to scroll through. In this case, there is free air in the upper abdomen and subtle stranding at the gastrojejunal anastomosis, which raises our concern. Taking a closer look, we can see the inflammation and dots of extraluminal air at the gastrojejunostomy. Marginal ulcers typically occur at the jejunal side of the gastroj. The operative report confirmed a 1 centimeter perforation just beyond the gastroj, which was treated with Omental patch. But air outside of the stomach isn't the only thing to be concerned about. Air in the gastric wall, also known as emphysematous gastritis, is caused by gas-forming infection with or without ischemia of the gastric wall. On endoscopy, this patient had extensive ulceration with necrosis and ischemia, but healing on repeat evaluation a few months later. Gastric varices are usually not a diagnostic dilemma, but they have important associations. This first example has numerous submucosal varices due to portal hypertension, and the second example has some short gastric varices coursing through the posterior fundus. We can scroll down a bit to find some more information in this case, and specifically a pancreas tail adenocarcinoma causing obstruction of the splenic vein, which has resulted in venous collateralization through the gastric veins into the stomach. So now that we've covered several inflammatory and infectious gastric pathologies, we're going to have to address the really bad actors in the bunch, and it is time to talk about cancer. Let's start this conversation by going back to wall thickening and expanding our differential beyond inflammation alone. As you know, inflammation of the stomach wall is relatively dark, which indicates edema. Lymphoma infiltrating the stomach wall will have a more intermediate attenuation wall thickening and often looks relatively bland and featureless without clear distinction of the mucosa and the media. And finally, infiltrative adenocarcinoma will often enhance and can appear quite bright. Notice how the tumor infiltration in this case is similar in overall brightness compared to the bright oral contrast within the stomach lumen. Gastric lymphoma can result in varying thickness of the wall and can get quite bulky, as in this second example. In keeping with the old radiology wisdom, it does in fact usually not obstruct because of the impact on the myenteric plexus or the innervation of the wall. This third example is a bit tougher to sort out as there's both tumor and ulceration, but you can start to distinguish the two by noticing the edema along the upper margin flanking some soft tissue here and the larger component of lymphomatous infiltration along the lower margin. So beware of the combination of both tumor and ulceration. Stomach infiltration is usually not the only manifestation of lymphoma. It is very helpful to try to tie it all together by looking for hints in other systems. Be sure to complete your search pattern by looking for adenopathy, organ infiltration, or other sites of disease in the rest of the GI tract to help you make the diagnosis. So as we wrap up lymphoma, remember that important findings that support your diagnosis include a bulky but non-obstructive mass in the bowel wall, solid organ masses or infiltration, and nodal disease in multiple distributions. When reporting, remember to keep your focus on practical, action-oriented steps. That is, what is the next step for the treatment team? And in the case of a new tumor or unknown tumor, it is to obtain a tissue diagnosis. Identifying a biopsy target in your report is a great way to keep patient care moving forward. And remember that a bowel wall mass can often be safely biopsied with ultrasound, helping to avoid an unnecessary surgery or bowel resection to make this diagnosis. Let's move along and discuss adenocarcinoma. Linitis plastica is an infiltrative subtype of gastric adenocarcinoma, which results in diffuse thickening and enhancement of the wall. It can be primary or metastatic, and it can start relatively subtle, like in this first example, which progressed to extensive thickening at 4 months. This third example of more extensive disease shows adjacent lymph nodes between the lesser gastric curvature and liver edge, supporting the diagnosis. Let's take some time to explore the key associations with this type of gastric cancer. When you're concerned about gastric adenocarcinoma, often you don't have to look farther than the gastrohepatic ligament for clues. Normally, there's just fat density between the lesser gastric curvature and liver edge with a few small lymph nodes and vessels. It's important to get comfortable with this location and recognize it as one of the first places that bad lymph nodes and thickening end up for gastroesophageal junction and gastric adenocarcinoma. Let's practice with a case of unknown gastric wall thickening. So what do you think the most likely cause is? Is this gastritis, lymphoma, or adenocarcinoma? There is soft tissue thickening and nodularity outside of the stomach wall, creeping along the gastrohepatic ligament. And what do we make of all of this ascites? And of course, the omentum is thickened with implants flapping around in this ascites. So even this relatively subtle thickening of the omentum is highly suspicious, so be sure to scan the peritoneal cavity carefully for signs of disease. This is peritoneal carcinomatosis. And when you're dealing with gastric cancer, you must become comfortable with catching carcinomatosis in its various presentations. It isn't always as obvious as this, but this advanced presentation of carcinomatosis would certainly be a giveaway and highlights the key features to look for. Here we have ascites, extensive omental caking, and nodular infiltration of the mesentery. Departing from the more classic presentations, it's also important to be prepared to think outside of the box and recognize new patterns of disease beyond omental cake and ascites. This patient has linitis plastica with infiltration of the gastrohepatic ligament, but also has coating nodular biliary and gallbladder metastases, as well as implants along the bladder dome. And this patient had a large, lobulated, and infiltrative gastric mass with many omental nodules, and a third important association in the pelvis, bilateral ovarian metastases, which are also known as Krukenberg tumors. Let's take a few moments to consider how masses might present differently in gastric bypass patients. It is important to become comfortable describing abnormalities of the afferent limb in the setting of gastric bypass patients. Using simpler terms, the afferent limb is the excluded stomach and proximal duodenum, and the jejunum, which later connects with the roux or alimentary limb. The excluded stomach should be relatively small and decompressed in these patients. It is often helpful to draw your understanding of the anatomy and where the problem is, which aids your communication to the surgical team and also your reporting. To refresh, bypass anatomy includes a roux limb or alimentary limb, and the majority of the stomach is excluded. And these gastric secretions, along with the bile and pancreas enzymes, which is known as the afferent or pancreaticobiliary limb, travel distally to the jejunal anastomosis. Obstruction occurring along this path can cause afferent loop obstruction and can occur as a result of adhesions, stricture, inflammation, internal hernia, or cancer. Afferent limb obstruction often leads to confusion in management, especially if you are interacting with a trainee or inexperienced resident. They hear you say obstruction and reflexively want to reach for a nasogastric tube. But the NG tube will not work in this case because the afferent limb obstruction occurs with bypass anatomy, and the roux or antegrade or alimentary limb is usually fine. It is the excluded stomach or pancreaticobiliary limb that's obstructed. So I like to make this very clear when I report cases like this, and it's often worth a phone call to directly tell the team that the patient has bypass anatomy and that nasogastric tube won't work in this case. In my impression, I try to describe the afferent and the roux limbs separately, or even use simpler terminology like excluded stomach or alimentary limb so everybody's on the same page. So let's go back to our patient. She presented with several-day history of worsening abdominal pain, and the excluded stomach is severely dilated with some thickening near the pylorus. The patient had a venting gastrostomy tube placed and underwent pyloric biopsy, which confirmed adenocarcinoma obstructing the excluded stomach. Let's wrap up adenocarcinoma with two practice cases. In this case, there is a relatively subtle amount of wall thickening along the lesser curvature. Remember that adenocarcinoma will usually leave clues. So what do you think? Is the lesser curvature a little too thick, or is this thickness due to underdistension? Notice how it looks more soft tissue in attenuation rather than low in attenuation or edematous, and that the stomach is otherwise pretty distended with oral contrast. Well, we don't have to scroll very far to find out some help to sort out this case. We spot these two huge gastroparetic lymph nodes which support a high suspicion of gastric adenocarcinoma, which was confirmed in this case. Let's wrap up gastric wall thickening with one last case and try to see if we can determine if the wall thickening is due to gastritis or from cancer. So drawing our attention here towards the pylorus where there's intermediate attenuation wall thickening, and I'll scroll up and down a couple more times to see if there's any other clues that jump out to you. The coronal image helps to lay out some of the key findings. So here, scrolling through the gastric antrum, and then we'll pay attention here to the pylorus, where there's intermediate attenuation wall thickening that looks to be having some enhancement with some bright oral contrast, but also these lymph nodes along the lower margin. So these lymph nodes are not reactive lymph nodes. They're not from inflammation in the setting of an ulcer. These lymph nodes are highly suspicious for cancer, and indeed, this is a gastric adenocarcinoma. There are a few other types of tumors to remember in your differential diagnosis. Gastrointestinal stromal tumors can occur in the stomach and small bowel. In the stomach, they tend to form well-defined, rounded submucosal masses when they're small, but can also grow to be quite large, as in this case. Carcinoid tumors of the stomach are rare, but may be more easily identified by their arterial hyperenhancement, as seen in this late arterial phase image. And finally, you may encounter a more diffuse picture of fold thickening or nodularity related to congenital polyposis. We have touched on gastric ulcers, and specifically to keep watch for the pattern of air, fluid, and inflammation to help guide your attention to the right upper quadrant. And I want to give you a few additional tips for your evaluation of duodenal ulcers. Remember that if the first portion perforates, which is the most common, you will have free intraperitoneal air. But if the second or third portions perforate, you will often have retroperitoneal air, though sometimes air and fluid can dissect through multiple planes. The ulcer craters or defects can be hard to see after perforation due to edema in that area, but oral contrast can often help to localize them. For our first case here, we'll look at a case of non-perforated ulcer. These can often be subtle and overlap at first glance with pancreatitis or duodenitis. And as I scroll through the duodenal bulb and first and second portion here along the pancreatico-duodenal groove, there is this rounded outpouching with surrounding inflammation. And we'll take another look at that on coronal as well. So almost like a mushroom type shape outpouching with surrounding inflammatory changes from a non-perforated ulcer. And before we head into some perforated ulcers, I just want to remind you again to look for that pattern of air, fluid, and inflammation that tips you off that there is a perforated ulcer. And in this first example of a perforated ulcer, we're going to look at free intraperitoneal air. And right away in the upper abdomen, there's multiple locules of free air. There's air within the fissure and along the gallbladder fossa, and also multiple dots of fluid. So this patient got some bright oral contrast, and scrolling through the junction of the first and second portion of the duodenum, here we can see this little outpouching of contrast and maybe some leakage of contrast here, which I think we can see to better effect overall on the coronal reformat, where there's some thickening and edema of the wall with some irregularity, and also some of that bright oral contrast leaking out through that lateral defect, coating somewhat along the lower edge of the gallbladder here, and also mixing with some lower attenuation fluid, creating this intermediate attenuation overall. For an example of a second portion perforation, we have air dissecting within the retroperitoneum. And anytime you have a chance to see retroperitoneal pathology, it can be really helpful to get a greater understanding of those spaces, because oftentimes those tissue planes are just fat density on CT and can blend in with each other. So here there's air and fluid and stranding extending along anterior and posterior pararenal spaces. And the coronal image here will show the site of defect and perforation along the medial margin of the second portion of the duodenum, with that air and fluid dissecting throughout the retroperitoneum. Let's take a quick detour and consider our differential for abdominal pain and free air. Often people will think of any source of perforation as equally likely in this case. Most commonly, we'll think of perforated appendicitis, diverticulitis, and perforated ulcers. But is that really the case? Are all three of these equally likely? In these three cases of perforated appendicitis, for example, let's ask ourselves, is there free air? The fluid, inflammation, and air are largely, if not completely, confined to the right lower quadrant. And similarly, in these cases of perforated sigmoid diverticulitis, we can ask ourselves, is there free air? And again, the fluid, air, and inflammation are confined to the pelvis and mesentery. Of course, there can be larger perforations causing air in the upper abdomen and below the diaphragm, but this is the typical presentation. So it turns out that upper abdominal free air, fluid, and inflammation strongly favor perforated ulcer from the stomach or duodenum. So look carefully even for subtle thickening or irregularity, and remember the benefits of using oral contrast for these exams. Now we're going to move on to a new topic, and things are going to get really exciting. We're going to talk about small bowel diverticulitis. And I really enjoy making this diagnosis, and it can be a bit mind-blowing when you first encounter it. Please remember that these diverticula are usually quite large and much larger than their colonic diverticular counterparts. And second, while there may be a temptation to wonder about the possibility of a perforated ulcer, remember that ulcers, when they perforate, do not typically form nicely walled off collections. Here's our first case of duodenal diverticulitis. And as we scroll down, it's not exactly an eye test. There's this large collection along the pancreaticoduodenal groove here. And it has a relatively thickened wall with surrounding inflammation and mottled dots of gas within it. And here we can look at the coronal image with the similar findings along the duodenal sweep. We see this collection or outpouching that is highly inflammatory with all those dots of gas within it. So while it's not necessary to have older studies to properly make this diagnosis, it certainly can help. And so this patient had an older study for comparison, which shows the decompressed and non-inflamed diverticulum, which helped to make a much more confident diagnosis in this case. Here is a very interesting case of jejunal diverticulitis. So let's take a little bit of time to talk about this diagnosis. So at first glance, you're dealing with a really similar kind of finding here, where we have a thick-walled inflammatory cavity, but this time there's this oval density within it with an air fluid level. And we'll look at some of the coronal images here that help to show its site of origin from this loop of jejunum here. This large kind of balloon-like cavity is arising from it with this oval density. And then in terms of dealing with small bowel diverticula and diverticulitis, I always like looking along the mesenteric border for other diverticula to increase my confidence in making this diagnosis. The patient was managed with antibiotics, but came back 5 days later with nausea, vomiting, and abdominal pain, and had imaging findings of a small bowel obstruction. The inflamed diverticulum is smaller, but no longer contains that oval enterolith. So that's the question, where did that enterolith go? As we follow the dilated small bowel into the right lower quadrant, we can find that structure here causing a small bowel obstruction, essentially an analog of gallstone ileus. The patient went to the operating room and had removal of the obstructive enterolith that had resulted from the initial presentation of jejunal diverticulitis. As a cautionary tale, let's take another look at a case of jejunal diverticulitis and discuss the importance of being confident in making this diagnosis. So certainly at first glance, this looks like an abscess cavity. It has a thick-walled, definite surrounding inflammation. There is mottled air and fluid within the collection, but we can also see a thin channel of communication with the jejunal lumen here. That might make you think at first glance, could this be perforation of the small bowel? But remember the possibility of diverticulitis when you're considering cases like this, and also the importance of looking for diverticula elsewhere to increase your confidence. So here along this mesenteric border of jejunum, we can find several other small diverticula. In this case, the possibility of abscess was raised, and the patient perhaps predictably went for a very common next step after an abscess is diagnosed, which is for percutaneous drainage. And the patient has here a pigtail catheter placed, which is injected with contrast, showing that thin channel of communication with the loop of jejunum. And so certainly the drain was eventually removed in this case, but it was also unnecessary and could have potentially placed some risk of fistula formation. So just remember the importance of confidently making the diagnosis when you can in this case to avoid unnecessary procedures or additional treatments when the primary therapy is antibiotics. Let's wrap up small bowel diverticulitis with an important item to consider on your differential diagnosis. This patient also presented acutely with abdominal pain, has an inflammatory looking collection here in the left abdomen with a linear density within it. There's an association of a thickened small bowel loop and also enlargement and myositis of the rectus abdominis muscle with erosion of that collection into the muscle belly. The sagittal image also highlights some of the findings and shows that linear density a little bit better here. And so as you look at these images, any ideas of what this could possibly be? This was a fishbone perforation, and these are sources of perforation that you should be aware of. All three can look like linear densities on CT and can be quite small and subtle, even looking like vessels, enhancing vessels at first glance. Fishbones and metallic grill brush bristles in particular can be very subtle, and sometimes with chicken bones you can see some differentiation between the cortex and the medullary cavity. For our last topic, we will cover the most common small bowel tumors, and we're going to start with a duodenal adenocarcinoma. So drawing our attention towards the first and second portion of the duodenum, there's some thickening and irregularity of the wall, which on these coronal images has an appearance that looks a lot like that characteristic apple core lesion that we have come to expect for colonic adenocarcinoma. And it's also really important to look at adjacent lymph nodes, even kind of borderline enlarged, portohepatis lymph nodes like these, which could raise your suspicion of local nodal spread. Here is a rather dramatic case of small bowel lymphoma involving the duodenum, where there's this bulky, somewhat ill-defined soft tissue mass with cavitation of the duodenal lumen, but also causing obstruction of the common bile duct towards the ampulla, which we'll get a little bit of a better sense of what's going on here on these coronal images, where you can see rapid tapering of the distal common bile duct here with a bulky soft tissue mass involving the junction of the second through third portion of the duodenum and also some extension of soft tissue into the mesentery. In this case of small bowel gastrointestinal stromal tumor, it is indeed a bit of an eye test, which can be the case for these smaller tumors, but also highlights the importance of having a systematic search pattern for evaluating the small bowel. So as I scroll up and down, perhaps you can see the tumor. We'll get a second chance on coronal, which often provides some really important second chances when looking for small bowel pathology. So here in the left abdomen, there is a heterogeneously enhancing mass with a few calcifications, perhaps a little bit concealed by some of the bright oral contrast in this case, or perhaps you feel that the oral contrast helps. It's a little hard to say in this one, but this is a gastrointestinal stromal tumor of the small bowel. That wraps up small bowel tumors. I have also included neuroendocrine tumor in that list as well, which can occur in the stomach or small bowel, but are much more common in the distal ileum and have that typical desmoplastic adenopathy to look out for. So that's our journey of CT pathology in the upper gastrointestinal tract. Let's wrap up with some highlights of the material that we've covered. As we evaluate the distal esophagus, we may encounter wall thickening from inflammation, cancer, or from perforation. CT esophagram is a helpful alternative to the fluoroscopic study and can provide more anatomic information, higher sensitivity for leaks, and be easier on busy daytime and after hours workflow. Two common cases of gastric inflammation are related to pancreatitis or peptic ulcer disease. When gastric or proximal duodenal ulcers perforate, you will usually see a predictable pattern of air, fluid, and inflammation to help you be more confident about your diagnosis. Less common gastric pathologies include emphysematous gastritis and Menetrier's disease. And finally, remember that the density of wall thickness will help you differentiate inflammation, lymphoma, and infiltrative adenocarcinoma. Cancer will usually leave clues such as gastrohepatic ligament adenopathy or carcinomatosis, and other important gastric tumor types to keep in mind include GIST, gastrointestinal stromal tumor, and carcinoid tumors. Perforated ulcers of the duodenum have a characteristic pattern of fluid, air, and inflammation, and oral contrast can aid in your detection of the ulcer defect. Small bowel diverticulitis can look a lot like an abscess at first glance, as they get much larger than their colonic counterparts. But you should be able to confidently make the diagnosis in most cases, especially by looking at old studies or finding diverticula elsewhere. We covered several examples of small bowel masses, including lymphoma, adenocarcinoma, and gastrointestinal stromal tumor. Thank you for your attention, and I hope that you have enjoyed this talk and found helpful material that